Hi, this is Dr. Bernstein with our November 2020 teleseminar. Before we read the routine questions, I have an important, very current question that I'm going to read, and then we'll go into the routine stuff. I live in Georgia, and our state is reopening during COVID. My daughter is 12-year-old type 1. We've been at home since March 13th, 2020. Should we continue to stay at home? Is she at risk of problems from COVID since she is a child? Also, should I send her back to school in the fall or find an alternative? She also has 2 siblings, 5 years old and 14 years old, in public school. Should I send them? Well, it's a lot of questions. I usually don't answer more than one at a time, but this is important. The important thing in dealing with the COVID epidemic is common sense. Use your head. Your kids are children, although the literature says that children other than infants may be less likely to develop a COVID infection. When they do develop an infection, it can be much more serious and can have long-term repercussions that can even last for life. So it certainly is not wise to let your kids get exposed. You're going to have to decide when it's time to go to school based upon obvious local circumstances. For example, what is the local incidence rate of COVID-19? If positive cases are running under 1%, there may be a low likelihood of infection. The ventilation of the schools or of the classrooms is essential to know about. There are some classrooms that have modern filtration systems that eliminate 99.98% of all particles. And these are new systems. Very unlikely that your school has them, but it's a possibility. In warmer weather, and you're in Georgia, you may have warm weather, the windows in the classrooms can be left open. That's a possibility. If they're not open, you better have a darn well good ventilation system. And even if you have a good ventilation system, is there safe distancing between students? And again, you have to use your judgment and be up to date on the literature. Some locales require 3-foot distancing and some 10-foot distancing. I would lean toward the 10-foot distancing, even when the windows are open or there's a good ventilation system. Are they wearing masks in the class? Are all the kids wearing masks, etc.? With regard to the 2 kids who are not diabetic, there's an additional problem, namely the fact that if you do get sick enough, they may give you dexamethasone, which is a potent steroid, and can possibly cause diabetes. So you don't want these other children to become diabetic. So there are lots of risks involved, and the important thing is common sense and not to get infected. Before we go into the usual questions, I want to remind you that the answers I give are generic answers that are meant for the general listener population and may not solve the problem of the individual who sent in the question. The purpose of these teleseminars is principally to educate a lot of people and not necessarily solve the problem for the individual, because I haven't done a physical exam, I haven't gotten his complete history, his family history, list of medications, etc. So any answer I give is a sheer guess and could be totally wrong. Okay. Hi, doctor. I am 36-year-old male weighing 143 pounds. I'm suffering from prediabetes for the last 1.5 years. Already not sure what prediabetes is. My A1C hovers around 5.6 to 6.0, which is on the high side, so he may be a pre-diabetic. I started a high protein, 150 gram diet in the last few weeks, and that's about 25 ounces of protein a day, which is a hefty amount, possibly a little more than a 143-pound person needs, but if he gets a lot of exercise, it may be reasonable. He doesn't talk about carbohydrate. My creatinine has risen from 0.8 to 1.06. I got so worried that I stopped eating that much protein. Please suggest. Well, first of all, it would be interesting to see if your serum creatinine drops when you reduce the amount of protein. However, your serum creatinine level is still normal, and serum creatinine levels vary with a lot of things that you may be doing. For example, if you exercise prior to the test, let's say for the 2 days prior to the test, you could raise the serum creatinine level, because creatinine is formed from the breakdown of proteins, of muscle. If you've been in a weight loss program, and some weight loss programs will cause breakdown of muscle tissue. For example, intermittent starvation will frequently cause fat loss and muscle loss, and that breakdown of muscle can raise creatinine. If you are fasting on the day that you do the blood test, your serum creatinine can go up. So if you're interested in serum creatinine, you should have a meal before the blood test. That's about all I can say. I would also advise you, if you think you're pre-diabetic, to reduce the carbohydrate load. And you might get my book, Diabetes Solution, or Diabetic Diet. 2 books, one or the other. Next question. As a type 1 diabetic, I've taken up a low-carb diet. However, recently I've been having symptoms of nausea, headaches, and lethargy. I had a look at my urinary ketones, and they were around 160 milligrams per deciliter. I then came across euglycemic DKA, and I'm concerned these systems may be due to high blood acid levels. Should I be concerned? And if so, do you have any suggestions as to how I can continue on a low-carb diet without causing euglycemic DKA? Well, First of all, if you're a type 1 diabetic, the important thing is blood sugars. And we have no mention of your blood sugars. You could have very high blood sugars and ketones in your urine. We don't know. You could be on a low carbohydrate diet. You could be on a low carbohydrate diet, but not eating enough protein. And as I said in probably the first article I got published in a scientific journal back around 1975, before I became a physician, the title of the article was Protein as the Principal Source of Carbohydrate. As the principal source of glucose in the treatment of type 1 diabetes. Your body does need glucose, but it can get it slowly from protein. And I've run into a number of people with self-imposed diets who are not getting enough protein, and that could be the cause of the excess ketones. If you have normal blood sugars, the ketone levels are not nearly as important as the potentially high blood sugar levels of a diabetic. Now, if you were sedentary and got no exercises, you would need about 1/5 of an ounce of protein per kilogram of blood sugar, kilogram of body weight per day. Let's see if that makes sense. It would be around 1 gram of protein per kilogram of blood sugar per day. That would help you to figure out how much you might need. And if you're physically active or exercise a lot, you might need much more protein. A professional athlete might need 20 times that amount of protein. How can a skinny LADA, that's latent immune diabetes of adulthood person, benefit from low carb diet? I am 48 years old, 5'6" tall, and only weigh 99 pounds. I use insulin, Tresiba, 4 units only in the morning, Nova Rapid, 3 units before breakfast. I ate only 60 carbs a day. My last A1C is 7.6. So this person has a very high average blood sugar. 7.6 is an average blood sugar of around 200. I started this diet 2 weeks ago, and I feel that my post-meal blood sugar is almost on range. I need to gain 5 kilograms. Well, he's going to have to cut down his carbohydrate. He's eating about 3 times as much carbohydrate a day as I eat, and I weigh more than he does, only a little more. I weigh about 108, 110, he weighs 99. So I get maybe 20 grams of protein a day, and he's getting 60. I'm sorry, 20 grams of carbohydrate a day, and he's getting 60. So he should have less carbohydrate, more protein, and normal blood sugars. I would suggest he read my book, Diabetes Solution, to find out how to get the normal blood sugars and how to work out a meal plan. Everyone keeps saying, get on an insulin pump. It's better and safer than injections. In your book, you come out pretty strongly against it. Has your position changed at all with recent advances in technology? Well, as far as I can tell, one part of the technology that is still going on is that physicians are indirectly getting kickbacks from pump manufacturers for recommending insulin pumps. They're put on their speaker board, given fees for speaking, and getting patient referrals and so on. So it's a very desirable technology for doctors. The adverse problems still exist. They haven't been changed. There have been some maybe improvements in the software, but the underlying assumptions are still wrong. The underlying assumptions for the software in these insulin pumps is that only carbohydrate should be covered by insulin, that protein, fat, and the bulk of the meal, that is the mass or volume of what you eat, has no effect on blood sugar, and this is absolutely false. And that you can eat whatever you want. Doesn't matter how fast acting it is, how slow acting the carbohydrate is, and guess at the amount of carbohydrate that you're eating. And the net result is that the whole ball game becomes a guess. On top of that, we have the fact that the catheter insertion sites in your skin are limited to a relatively small area of your body. You can't, for example, put a catheter in your butt, which is the best place for insulin injections. The net result is that you develop scar tissue over time that both makes the absorption of insulin from the catheter a less amount of absorption, but less predictable. So you not only are injecting unpredictable amounts based upon unpredictable guesses of what your insulin should be for the amount of food you're eating, but you're also injecting into scar tissue where the amount absorbed and the timing of the absorption is unpredictable. 30-year-old male type 1 diabetic since 1998. I am very overweight. Body mass index of over 30. I've been following your diet religiously. I feel I am extremely insulin resistant. I lost 15 pounds in 5 weeks. Fortunately, blood sugars are well controlled between 75 to 95 all day, which is pretty amazing for a type 1 diabetic. But I guess he may have read my book. Yeah, I've been following your diet. Would glucophage XR benefit me to further my weight loss? My guess is that it might. In overweight people, it frequently lowers insulin resistance and makes you more sensitive to the insulin you're injecting, allowing you to inject smaller doses of insulin. And since insulin is a fat-building hormone, it's also muscle-building, you're more likely to lose fat with the same blood sugars. You'll be requiring less insulin, but having the same blood sugars, if it works. And if you're going to start glucophage, you should start it slowly. Take the first dose after a meal, and continue after meals if you initially have diarrhea or any GI distress. Usually the GI distress goes away after a period of weeks, in extreme cases months, and then when the GI distress goes away, you start a second dose, which you might have, if you have the first dose in the morning, you might take the second in the evening, etc. And you gradually lower your insulin if your blood sugars drop. Do you have any recommendations for a 1-year-old who was diagnosed with type 1 diabetes a couple of months ago to help preserve any beta cells he may have left? Well, first of all, I'd advise that you read my book for treating him. You're probably going to need diluted regular insulin before meals and for correcting elevated blood sugars. You might require a very tiny amount of Tresiba insulin, long-acting insulin, and a tiny amount might be a quarter of a unit once or twice a day. The usual blood sugars of non-diabetic 1-year-olds are probably around 65 milligram per deciliter, and I would shoot for 75 just to play it safe. But you have a very narrow range of target of blood sugars that you can tolerate, because you go down from 75 by 30 and you're only at 45, and that might not be very far away from 20, which could lead to loss of consciousness or convulsions. So you have to be very careful. Normal blood sugars tend to preserve beta cell function because high glucose is toxic to beta cells. "11-year-old girl, type 1 diabetic for 6 years. I read your book and am curious, does this diet affect her growth, like shortage of vitamins or minerals? If yes, please tell us what to do. Thanks." The answer is no, but we do try to encourage the use of vegetables. Vegetables with slow-acting carbohydrate. And this is all covered in the book. We have one page that I think lists maybe 30 vegetables that are acceptable, and the quantities have to be measured, etc. And what has been found with regard to growth, and I've seen it in my own patients. I just had one girl, a 12-year-old girl from Bermuda, who went back onto the growth curve that she had before she developed diabetes. When she developed diabetes, she was, prior to developing diabetes, she was on the 50% line of the growth curve chart. And when she developed diabetes and her blood sugars were elevated, she went below the 50th percentile. I think she went down to 25 on both height and weight. And then after we got her blood sugars controlled, she's back up to the 50th percentile. How many ounces of cheese is allowed as part of your daily diet plan? Well, first of all, it depends if you like cheese. Some people like cheese, some people like certain cheeses, some people hate cheese, so you don't want to force somebody to eat cheese. Some people don't like red meat, and although we try to give them at least a little bit of red meat to maintain their hematocrit and facilitate muscle growth, we need enough protein in the diet to maintain muscle mass. So I previously have stated how much protein you need for an inactive adult, and I've pointed out that for active people you need a lot of protein. So there may be many ounces of cheese that would help build up your protein load. I can't think of a limit. On the upside, it's trial and error. You look at your blood sugars and so on. But read my book, Diabetes Solution. It might clarify things. How much higher risk for COVID-19 infections and COVID-19 infection complications is a type 2 diabetic with virtually normal blood sugars? Well, the literature shows that there's newer literature than I've discussed previously. Not only are inflammatory markers elevated when blood sugars are elevated, but also additional damage to the body goes up with blood sugar elevation. I can't tell you how much, but it's certainly safer to have normal blood sugars, but you're not going to prevent infection or prevent the sequelae of COVID-19 by normal blood sugars. You just reduce the likelihood. And I can't tell you how much you reduce the likelihood. How the new insulin Fiasp can help on controlling high blood sugar. Well, Fiasp is a rapid-acting insulin. It's made by Novo. It consists of Novolog with the addition of L-arginine, which is a precursor of nitric oxide, which is a vasodilator, dilates blood vessels so that the insulin that's in the subcutaneous tissue gets into the bloodstream more rapidly. So Fiasp is faster than Humalog. It's probably just as potent as Humalog. I would rarely recommend it for a patient before meals. I would recommend it, as this person suggests, for bringing down elevated blood sugars, but you have to be careful that this stuff is so potent, it could lower you more than you want. Another good reason for reading my book, Diabetes Solution, which does discuss the potency of Humalog versus regular. Now, one question that you should have asked was, can Fiasp be diluted as Humalog can be diluted? And I don't know the answer to that. You might be changing the speed of action if you dilute it. I've contacted Novo, and they have no idea. They'd never thought of the question, and no one else has ever asked it. I'm following your diet, but suddenly after I'd tried probiotics included in my regimen, my intestine refuses to move. Constipation. I feel like paralyzed inside. What medication does the least harm? Well, if the probiotics cause the problem, I would stop the probiotics. I've, on my teleseminars and my videos, recommended against the haphazard use of probiotics, although I recommend their use if you're taking oral antibiotics to help restore intestinal flora. If you take probiotics for no purpose, you're going to change your microbiome, the microbiome that's evolved with you over your lifetime and is probably doing you good and is benefiting from the parasitic interaction with you. And you throw in some new organisms that are different from the ones that grew up with you, you're asking for trouble. And so what I would do is stop the probiotics. I am a 68-year-old female who was diagnosed with type 1 diabetes 5 years ago. I was trying to keep my blood sugar level with some medications such as metformin. Well, she says type 1 diabetes. Metformin is not the usual treatment. It worked for a while but stopped after 4 years. I am on insulin Tresiba now, and I eat very little carbohydrate. My fasting sugar level could range from 100 to 130. So this person is not even looking at her blood sugars after meals. The chances are, if she's really a type 1 diabetic, which I question, that she's going up after meals because she's not taking rapid-acting insulin before meals. So, again, person should read my book to learn how to use insulin. And you have to be very careful with insulin so you don't just start taking it in a haphazard fashion as some diabetes educators recommend. Read the book. 37-year-old type 1 diabetic. Thanks to your diet, I was able to bring down my A1C from 13, which is an average blood sugar of about 400, to 4.7, which is pretty darn good. But lipoprotein A, as it is at 55, that's lipoprotein small a, should be 20. And my guess is, and I could be wrong, that this is a female and she's 37 years old. She may have had a hysterectomy is my guess, because in my experience, the most common and most dramatic cause of high lipoprotein small a, which is a very potent cardiac risk factor, is low estrogen levels in women. So if she had a total hysterectomy with removal of her ovaries, that would explain the high lipo small a. And her lipo small a isn't anywhere near what I've seen in people who have had hysterectomies. If she has not had a hysterectomy, question is she menstruating? And if she's not menstruating, she may have low estrogen levels. So if she's not had a hysterectomy, she should see a reproductive endocrinologist. If she has had a hysterectomy, she should see a a reproductive endocrinologist for prescription of estrogen replacement. And I've seen lipo small a go down when these people have estrogen replacement. I'm a thin type 1, almost no C-peptide, meaning that he or she is almost making no insulin. Like most type 1s, that is, not making insulin. If I eat one apple with 15 grams of carb, my blood sugar goes up by 150 points. Well, that's exactly what happened to me. Actually, I would go up by 12 times 15, I'd go up by 180. If I become obese, then will my blood sugars still raise up 150 points when eating 15 grams of an apple? In other words, a person saying if he gets fatter and has more body weight and is dividing that glucose over a greater weight, will he still go up by 150? So I guess he's planning to get obese and wants to know if he could only go up 150 points if he has apples. I know that it'll take more insulin to bring down my blood sugar because I'm obese and type 1. But will my blood sugar raise up differently to the same 15? Well, I would say that you give it a try. Why do you have to ask me? I don't advise that you eat any apples. I'm sure I haven't had an apple since probably 1972 or 1973, which is a long time. That's close to 50 years. Likewise for bread. I'm a type 2 diabetic and I'm taking levothyroxine, that's T4, 100 micrograms for underactive thyroid. When I woke this morning at 5:30 a.m., my glucose was 144. I take my thyroid medication at 7 a.m. and 7:30 a.m. before preparing my breakfast. My glucose was 176. At 7:30 a.m. before preparing my breakfast, my glucose was 176. So we went up from 144 to 176. Does thyroid medication affect blood sugars to that degree? First of all, T4, levothyroxine, is very slow acting. It takes about 2 months for it to have its full effect on your serum thyroid levels and your body thyroid levels. So I cannot possibly blame T4. It's a possibility that T3, if you were taking it, might have that effect, but it's far more common with type 1 diabetics to have the dawn phenomenon. And if you want to know about the dawn phenomenon, you listen to my videos or read my book, Diabetes Solution. I'm a type 2 diabetic for 20 years. I'm taking metformin, glucophage, 2,000 milligrams a day, Jordance, which is an SGL2 inhibitor, and insulin Tresiba, 14 units twice a day, which is a pretty hefty dose. So this person may be overweight. My A1C was 5.6 last time. It's an average blood sugar of about 124. Do you think I'm taking too much insulin? It really depends upon your actual blood sugars and your body weight. As I said, 14 units twice a day is a lot of basal insulin. But if your blood sugars are not going too low, it may be what you need, or it may be more like the old ADA method of treating diabetes, which was to give a long-acting insulin once or twice a day in a dose that would force them to eat all day long. And I don't know whether that's happening with you. So again, I suggest you read my book. It'll probably the first thing you should do is be on a low carbohydrate diet. I have a feeling that you're overweight, so you should be losing weight. And read the book and you'll be able to figure out whether you're getting too much insulin. My guess is you probably need less Tresiba and rapid-acting insulin before meals, but I can't be sure. I'm having a lot of trouble with my Dexcom 6 new, my new freestyle meter says 99 and the Dexcom says 146 and going down. This happens all the time. What is the point of having this if I don't have hypoglycemia unawareness? 46 years on insulin, testing 10 times a day until a few months ago when I switched to a continuous glucose monitor. Well, first of all, as I've pointed out over and over, you don't switch to a continuous glucose monitor to cut down on your finger sticks. That's what the advertising says, but the advertising is a lie. You have to rely on your actual blood sugar readings, which you get from the finger sticks. I have a CGM right here on my arm, and I have a Dexcom 6, and it frequently is wrong. If my blood sugar is steady, the Dexcom 6 is steady. If my blood sugar is rapidly changing, the Dexcom 6 will be typically 20 to 30 minutes behind my blood sugar. So, if you were 146 and rapidly dropping, for whatever reason, you took a shot of insulin to bring you down, you could have been 146 for real 30 minutes ago, but now your meter reads 99, you could be 99. Don't rely on the Dexcom. Use it for warnings. I have it set for a very loud alarm. I have it set for a European police van with all sirens going, and it wakes me up at night if I go too low. That's why I have it. I'm not particularly worried about the daytime, but I am worried about nighttime. So that's why I have a Dexcom 6. And frequently it's right on the nose, and frequently it's a half hour behind my freestyle meter if my blood sugar is changing rapidly. And I might add to that I certainly do many more blood sugars since I've had the Dexcom 6, because I do get false alarms and I can't trust the Dexcom readings, even though they're usually, my blood sugar is usually pretty level and they're usually very good right on the nose with my freestyle. But still, if I get a warning, I better check it on my freestyle meter. I am having trouble maintaining my daughter's weight. She is 12 years old. Her starting weight at endo was 82 pounds, and now 5 months later, it's 78 pounds. She takes Tresiba 2 units at night. That's all she's taking, which she may be in the honeymoon period. We are following your plan, and we have increased protein. She is drinking whey protein shake daily, but weight will not increase. Well, first of all, I would think that you should be giving her protein foods. Let's see what else they say. But she eats until she is full. So she's not eating full meals. Her A1Cs went from 6.2 to 5. 5's about 100 milligrams per deciliter. Any advice you give would be appreciated. First of all, I'd advise that you give her real food. She's not trying to lose weight. She doesn't have gastroparesis. She should be getting vegetables, again, according to the guidelines in my book. She's probably big enough to get 6, 12, and 12 on the carbohydrate. She should have normal blood sugars for her age are lower than 100. They're more like 75. So when you have, and she probably should have diluted insulin before meals so that she doesn't go up after meals. And as I said, the target should be about 75. Now, the big problem is that she stops eating when she gets full. That is why she's not gaining weight. That's one of the reasons why. And we have a lot of kids like that. And you can't force a kid to eat more than they can handle. So you might want to institute covered snacks that are covered with diluted insulin. So she's full after lunch. She might start getting hungry again 3 hours later. You give her a high protein snack and you cover it with insulin. Now, what I've seen with my kids who are in the honeymoon period, and many of these kids have honeymoon periods that are going on for 5 years now, we may find that if they have 1 ounce of protein for the snack, they don't need any insulin. They're still making insulin. But if they have 2 ounces of protein, we have to cover it with some diluted insulin. That's a typical situation. So I think that she should be getting snacks that are covered with insulin. They should be high protein snacks with whatever fat comes along with the protein. Some people like cheese sticks, some like cheese slices, some like these pepperoni sticks, some like beef jerky, but you have a constant amount that you would have for each snack. So you might have 1 beef jerky for an uncovered snack and 2 beef jerkies for a covered snack, etc. And you adjust the snack to what the kid likes. I'm a type 1 for 11 years, have read your book and have found it to be extremely helpful. I am trying to conceive and want to know if you believe Tresiba is safe during pregnancy. My OBGYN wants me to switch to Levemir, but another provider does not believe this is necessary. Well, I haven't seen anything in my readings about any adverse effects of Tresiba during pregnancy. You might want to do a literature search, search the peer-reviewed scientific literature, for Tresiba insulin and during pregnancy. See what you come up with. My guess is you won't come up with anything, or you'll come up with opinions saying it's safe in the experience of a variety of physicians. Opinions are not as good as scientific studies. I'm a type 1 and take Lantus pen and Humalog pen. Can I normalize my sugar with the pens, or do I have to use syringes to achieve normal blood sugar? Well, I would suggest that you can first try with, wait a second, a Humalog pen is too rapid for a low carbohydrate diet. Humalog was designed for ADA, high carbohydrate, sweet food diets. And you can't get normal blood sugars with that. I do have one or two patients who may use Humalog or diluted Humalog for the, I should say diluted Humalog for the dawn phenomenon, or for one meal a day, and regular insulin or diluted regular for other meals. I usually use Humalog or diluted Humalog to correct elevated blood sugars. But unless you're very obese and therefore very insulin resistant, the high potency of Humalog, which is double that of regular, makes fine-tuning of doses impossible. I might add that a half-unit Humalog pen is available, but even half units of Humalog are quite potent. For example, 1 unit of Humalog will lower me by 120, a half unit will lower me by 60, a half unit of regular will lower me by 30. So it's hard to work with Humalog. As far as Lantus goes, it's not as long-acting as Tresiba. Tresiba does come in a pen. The pen, unfortunately, will not give half units. If you're interested in messing around with pens, you could, oh wait, there's no half unit Tresiba pen. No. Using pens, you frequently get leaks. So as I previously advised, you have to wipe your skin after a shot to see if any insulin is leaked out of the injection site. And as a rule, you should not use a needle any shorter than 6 or 8 millimeters. Probably 8 is the necessary length to minimize leakage, but you could still get leakage, and you have to, you should probably hold the button down when you inject with a pen for about 50 seconds. They recommend 20 seconds. I would recommend to play it safe 50. You could try 20, see if you get leakage by feeling the injection site with your hand. If the site's wet, you know that you may need 50. Now, I have patients who get leakage from the pens no matter what dose they inject. So there are problems. If you can keep your blood sugars normal and level, well, first of all, you'd have to use my book to do that. If you could do it with pens, great. If you can't, you have to switch the syringes. And it's very hard to inject diluted insulin which most of my patients require because many of them are type 2s or children. Um, and it's very hard to get diluted insulin into a pen. You would have to take empty cartridges and inject the diluted insulin into the cartridges used in the pen. I'm a type 2 diabetic. I've been in low-carb diet and intermittent fasting for 3 months. In the first 2 months, I had perfect fasting blood sugars, and very normal random blood sugar never gets over 100. I don't take any medications. In the last 4 weeks, my fasting blood sugar started to rise to 110 or 113, yet I'm still in the same diet, and fasting hours or even longer, up to 20 hours. Can you please explain why this might be? My guess is that this person might have been only recently diagnosed. She's been on low carb and intermittent fasting for 3 months. Could be that she's burning out beta cells. And you could do that by having high blood sugars, by eating a lot of carbohydrate. Now, she's, according to what I'm reading, it looks like she never checks her post-meal blood sugars. So she should be checking her blood sugar 1 and 2 hours after meals to see what's happening. And if she's going up after meals, the high blood sugars are toxic to beta cells, and that can cause beta cell burnout. The intermittent fasting has problems in that you tend to lose weight, so I guess she may be overweight. I said she, but it could be a he. And with the intermittent fasting, we've seen patients lose both fat and muscle, and then they stop the fasting and they gain back the fat, but not most of the muscle. So my guess is beta cell burnout due to elevated blood sugars after meals. That's just a guess. I'm a type 2 for 30 years, on insulin for 20 years, trying to reduce the amount and finding it impossible to lose weight. Following the 6-12-12 plan, reduced my dosing to 7 units basal. How to reduce the amount I'm using overall? Well, you could exercise, and I have one lady who couldn't lose weight, and she was not exercising because she had had surgery to a foot and to a shoulder, and was afraid that she couldn't do any kind of exercise. Well, we just worked out a host of exercises with dumbbells that don't affect her foot and her shoulder. So you could be, I exercise every day. I do 8 exercises each day for a total of 30 different exercises. And on twice a week, I skip the 8 exercises and do an elliptical exercise that gets my heart rate above my theoretical maximum. Now, I'm not recommending this for you because you could kill yourself doing that. I've been doing this kind of exercise since I was in my 30s. So I'm in shape to do it. But exercise could help. Now, if you're already on the 6-12-12 diet, you may be getting too much protein, and there are ways of computing this that I've discussed in my videos, and that's another possibility, but my main thought is the exercise. There's also the use of metformin, which can reduce insulin resistance. There are other substances that reduce insulin resistance, but I wouldn't recommend any of them right now. I think the metformin and exercise come first. Anything else is way down on my list. Well, that's it for our November teleseminar and video. Please come with me on Wednesday, December 30th for our final session of the year. I look forward to seeing you then. I'm looking right at you now. Thank you.